Good afternoon. My name is Dean Kim. I'm the surgical director of the kidney and pancreas transplant program, for those who don't know me. And it is my pleasure to introduce our grand round speaker today. I know her very well since she is the medical director of the kidney and pancreas transplant program, or I guess the kidney program now. But after reviewing her CV, I was impressed with her academic accomplishments. So I actually took some notes here. So bear with me here. Okay, so Dr. Prashar received her medical degree at the Government Medical College in Punjab, India in 2007. An interesting fact is that she was a National Talent Search Examination Scholarship winner for the government of India, which is probably no small feat. After that, she came to do her internal medicine residency at St. Vincent Mercy Medical Center in Toledo, Ohio. She served as a chief resident her final year. After that, she went down to do her nephrology fellowship at the University of Toledo Medical Center, where she was the fellow of the year in her first year there. So all these great accomplishments. Then we were fortunate enough to recruit her to our transplant nephrology fellowship, where she excelled, and she was offered a position here. And then finally, she received her master's in public health at one of the foremost institutions that offers that degree, the Johns Hopkins University Bloomberg School of Public Health. She became assistant professor of medicine at Wayne State University and senior staff physician in transplant nephrology here since 2015. She's board certified in both internal medicine and in nephrology. And as she has matured, she has been given more and more responsibility, and she is currently serving as the medical director for the kidney transplant program. Now, she's participated in many clinical trials that we do here at Henry Ford Hospital, and she serves as both sub-PI, principal investigator, as well as the site principal investigator. But perhaps most notable is her ongoing role as the site PI for the multi-center NIH-sponsored APOL-1 long-term kidney transplant outcomes network. It's a mouthful. The APOLLO study. And so she's uniquely qualified to talk about her current talk, which is the APOL-1 genetic variant in living donor kidney donation. So I'm happy to introduce Dr. Prashar.
Thank you, Dr. Kim. That was very flattering. I'd forgotten some of these things about myself. Thank you. Thank you. So yes, I'll talk about APOL-1 genetic variants, mostly in context of living kidney donation. I want to start my talk with this landmark picture. This is Richard and Ronald Herrick, the donor and recipient of the first ever kidney transplant in 1954. Brigham and Women's. This was a very auspicious start to the field of transplantation. A lot has changed in the field of transplant since then. We've made great advancements in immunosuppression. From a regulatory standpoint, NOTA was implemented in 1984. Living donor transplant has expanded to include KPDs. We have made such immunological advancements, immunosuppression, surgical techniques, and over time, the access to transplantation, it's expanded to people of all races and ethnicities. However, in spite of all of this, there are a few things that have remained constant. Receiving a live kidney transplant is the best option for patients with ESRD. That hasn't changed. Unlike any other specialty of medicine, we potentially endanger the health of one person over the other. Living kidney donation is accepted on the premise that we are posing minimal risk to the health of the donor. And over the last decade, there's been some evidence that this may not hold true for African-American donors, specifically in the context of APOL-1 gene variation in this population. So at this junction, I want to introduce a patient scenario, which might be much too familiar to some of you that work with living kidney donors, and I've changed their name for confidentiality. So George, a 32-year-old male, he was highly motivated to donate a kidney to his brother, who was in mid-30s. whose kidney disease was ascribed to hypertension. The brothers were compatible in terms of your blood type, and in fact, he was a perfect match, a 2 haplotype HLA match. The history, physical examination, psychosocial exam, lab studies were all normal, GFR was great. He was offered and accepted genetic testing and was found to be homozygous for high-risk variants of APOL-1 gene. After discussing the finding with him, his request to donate his kidney to his brother was declined, much to his disappointment. So is this decision controversial? So if you look at it purely from a medical lens, this decision, seemed very uncontroversial because when we look at the overriding focus of our evaluation, we look at two things. We want to prevent the biggest risks of all, which is the rare incidence of postoperative death and occasional incidence of chronic kidney disease down the line. So if you look through this lens, like I said, it is probably a very uncontroversial decision. George was most certainly at an increased risk based on his African ancestry, young age, his family history, and his genetic makeup. Now, if we take the medical hat off, right, and we consider the donor's health in a holistic manner rather than strictly medical fashion, there are some other benefits to donation, which is personal growth, self-esteem to the donor, this joy that donation brings to, once you are a source of health to a loved one. You all remember Dr. Simpson's talk from last week. We, by declining donors solely based on their genetic makeup, are potentially exacerbating pre-existing disparities that exist in this subset of the population. So, we could look at this case through a holistic approach rather than just purely medical. And there might be circumstances in which the increasing element of physical risk to the donor might be justified. This is what people call discretionary donation at times. And let's say this was a mother wanting to donate to a child who had prediabetes and a risk of developing diabetes in the future. Sometimes we make those decisions, and that's what we call discretionary donation. Now, if George donated, and he developed kidney failure and had fully accepted the risk, considered the risk, it would be a manifestation of his choice and not something that was done to him by us. So if something were to happen to be him in the future, that would be unfortunate, foreseeable, but that was his decision. So can that argument be made to APOL-1 disease variants as well? So that's what I wanted to discuss through my talk today, to understand where these variants came from and their significance in chronic kidney disease. So the objectives of my talk are going to be to understand the evolutionary adaptation. How did the APOL-1 risk variants come into picture, and how are they associated with kidney disease? Discuss APOL-1 and kidney transplant recipient outcomes in patients who received those kidneys, and then review current state of knowledge regarding APOL-1 renal risk variants and kidney disease in living donors, and then discuss the dilemma that I just discussed, ethical challenges and practical consideration of testing and how to use the results of that testing. So who recognizes this insect? So the story behind how APOL-1 variants were produced is evolutionary. Okay, so this is the tsetse fly. You remember from medical school. It's associated with human African trypanosomiasis. It's also called sleeping sickness. And we wouldn't be talking of APOL-1 now, today, mutation today, if this fly, or if this, fly didn't do what it was supposed to do. So APOL-1, the gene, it is from the APOL gene family. There are 6 genes in human chromosome 22. It's the circulating factor that confers resistance to Trypanosoma brucei, which causes trypanosomiasis. It has 2 subspecies. I won't go into the details, but it causes human African sleeping sickness across the sub-Saharan Africa. And it circulates on the HDL particles, which is the primary nutrient source for these parasites called trypanosomes. So like I said, the story is evolutionary. The way it was originally designed to be is that figure A, where APOL-1 containing HDL particle, it gets taken by the parasite, which is trypanosoma, and then it causes lysosomal swelling and death of this parasite. So that was how it was supposed to be. Over time, this parasite developed what we call SRA, serum-resistant associated factor, which made it resistant, the lysosomes resistant to the penetration, so that these parasites would survive, right? And when these parasites would survive, that's how people would get the sleeping sickness. Over time, human body mutated to protect those humans in sub-Saharan Africa from the sleeping sickness. So the mutation was in the APOL-1 gene, G1 and G2. So that's your C. So now when you have that mutation, this APOL-1 complex cannot attack the lysosome and it cannot kill the parasite. It can kill the parasite, sorry. So generally, trypanosoma, there are two trypanosomas. One is gambians and one is Rhodesians. The more common one is gambicens. It's endemic in 24 countries in Central and West Africa. It's causing 98% cases of the African sleeping sickness. So the CC fly actually is the one that carries the parasite from one human to the other, causes African sleeping sickness. So over time, to protect the native population from African sleeping sickness, mutations developed, right? So the mutations were in G1 and G2 gene. So this is where it is. And this is where the mutations were. So this is all sub-Saharan Africa. And if you see, G1 mutation was more common in the Western Africa, and G2 mutation was, I'm sorry, G1 in Western Africa and G2, more on the eastern side. So how does kidney disease come into picture? So now this mutation was originally designed, or the way it evolved was to protect patients from the sleeping sickness, to protect native Africans from the sleeping sickness. And only one APOL-1 variant is necessary to protect anybody against trypanosomiasis. And if somebody had two, and that's natural selection, if somebody had two APOL-1 risk variants, that actually could cause excess kidney disease. And if you have a combination of G1 and G2, that could also cause excess kidney disease. So when we came to know about this association, we started calling this G1 and G2 as renal risk variants. So to make it easy, to summarize, so when your trypanosoma, somebody had that infection with APOL-1, normal APOL-1, new mutations, you are at risk of no kidney disease, but you could get trypanosomiasis. When you get one mutation, you don't get trypanosomiasis, you don't get kidney disease. But in the evolution, if you get two mutations, you don't get trypanosomiasis, but you are at a risk of chronic kidney disease. So this is sort of how it's evolved over time. What's the kidney disease mechanism? In CJS, and Dr. Friedman described it very well. So basically, we don't know what is the normal function of APOL-1 in human kidneys. We do know that risk variants of APOL-1 is cytotoxic to the nephrons, and it's mainly in the glomeruli. We call it primary podocytopathy, which is in the glomeruli. That's where it affects. I won't go into details of that. But why do we think that only a certain subset of population is affected by these? So APOL-1 risk variants, like I described, they arose in Africa 4,000 years ago. Now, Europeans left Africa many millennia before even the origin of risk variants. So this migration from West Africa to Europe happened like 20,000 to 100,000 years ago. So if you look at European Africans, they don't have this mutation. On the other hand, the migration of West Africans to the US happened about 400 years ago. This was after those mutations had happened in the Western sub-Saharan Africa. So this is where we see these risk variants. So in the US, most of the blacks, 80% have African ancestry and 20% have Europeans. And the risk variants are found in African Americans, the Africans who have, the black patients who have African ancestry and not European. Outside of the US, if you look at the distribution of the risk variants, you see it very concentrated in the Western African region. The purple one is highest predominance of risk variants in the Western African region, and then in the Caribbean. So you have quite a bit of these people who migrated to that area. As I said, in the US, blacks have 80% African ancestry and 20% European. So when you looked at genome-wide association of risk of kidney disease, we've always said African Americans have a higher risk of kidney disease. And when we looked at genome-wide association, we really didn't find much difference. These were the controls and these were the cases, like not much difference in the genetic makeup. But when we came to know, in the late 2008-29 about this APOL-1 and the risk. And then when we looked at specifically chromosome 22, we could see that African Americans have more of that mutation than the others. And that's how we started thinking, is there an association with APOL-1 mutation and kidney disease in Americans of African origin? And if you look at the spectrum of nephropathy, kidney disease is huge. Even in African American, that spectrum of kidney disease is huge. You don't see it in every disease. You won't see it in IgA nephropathy, for example. But it was mostly associated with HIVAN, HIV-associated nephropathy, or primary FSGS. And the odds ratio for these, if you have an APOL1 risk variant, is very high, up to 17 to 25. And now, how do these findings, there's APOL1, now you could make a correlation through looking at the genomic analysis, but how do these findings translate into clinical practice, and what is the evidence? So this was very elegantly detailed in studies by Dr. Kopp in 2011. There was this nice study in JASN, where he retrospectively genotyped 271 African-American cases, and then he had 939 controls. So he compared African Americans with primary FSGS with normal blood African American blood donors. He also compared African Americans with HIVAN with other HIV positive patients without nephropathy. And then he also compared primary FSGS in Europeans to normal blood donors in European Americans. And what he found was that patients with two risk variants, which is we call two risk alleles, have 17-fold higher odds for FSGS, 29-fold higher odds for HIVAN. Those were the diseases that were more predominantly associated with the gene. And actually, the genetic mutation explains 18% of the FSGS cases. It explains 35% of HIV-associated nephropathy cases. And if you eliminated the risk of these alleles in a recessive model, you would decrease the risk of FSGS and HIVAN by 67%. So that firmly established in 2011 through 2015, that firmly established the relationship between APOL1 and kidney disease in the African-American population. Another interesting thing to find, which I think might become more relevant as we evaluate donors, is that usually the age of onset of primary FSGS for APOL1, it's younger. When people who have two risk alleles, if they have FSGS, they manifest it at a younger age. So I think that was kind of interesting in Dr. Kopp's findings. Now, over time, these findings were replicated in various other studies. There were two big trials, the ASK trial, which looked at CKD in non-diabetics, and the CRIC trial, which looked at CKD in diabetics, and all these findings were replicated in those trials. Now, could we replicate these findings in the transplant population? In 2009, before we started looking at APOL1 in detail, Dr. Callender described lower allograft survival in African-American deceased donor kidneys when they were transplanted into patients of African or European ancestry. You're right here, your risk bars are above the line. So could APOL1 be the likely explanation of Dr. Callender's findings? Why are we seeing that African-American kidneys, after adjusting for everything else, were lasting, less amount of time than non-African-American kidneys? So one of the initial studies to look at this discrepancy, could APOL1 explain that? It was done at Wake Forest. Even now Wake Forest is the place we send our samples to for testing. So they do a lot of work there. And this was a retrospective study. It was done on African-Americans in deceased donors, 2011. And then they should have been at least followed up for 1 year. And donor APOL1 high-risk alleles, what they found was there was increase in graft failure as compared to patients with low-risk APOL1 disease with a hazard ratio of 3.84. So they replicated those. So they had an explanation for Dr. Calendar's findings that APOL1 could be the reason why African American kidneys were failing sooner after adjusting for all these other factors. So there was another study which looked at APOL1 gene and allograft survival after kidney transplantation. They had 8 cases with they were followed up for 2 years post-transplant, and they had 8 cases with 2 risk APOL1 variants which had graft loss in 2 years after transplant. And APOL1 associated lesions, which is collapsing FSGS, mostly was present in 6 of 8 of these cases. Podocytes, yep. Then there was a study that was replicated. Same study was replicated in 2015, genotyping 675 donors in Wake Forest and UAB. And the Kaplan-Meier allograft survival curves demonstrated separation at 2 years. So until 2 years, the function was about similar. But at 2 years, APOL1 high-risk alleles caused more graft failure. So the hazard ratio was 2.21. But interestingly, and I think that's where we need to be very careful interpreting this data in deceased donor kidneys, is most transplanted kidneys with 2 risk alleles didn't fail early. So 54.5% was still functioning at 10 years. So when you have no other option, this is certainly a reasonable option. But at least the initial data points towards risk of graft loss eventually in these kidneys. So I wanted to share Detroit experience with you as well. We did a study, this was Henry Ford and Wayne State, with an aim to compare allograft survival in kidney transplants from African-American donors with high versus low risk APOL1 risk alleles. So our donor recruitment was, so this was Henry Ford and Wayne State University School of Medicine, their transplant program before they had closed. So we had deceased donors, African-American deceased donors from 2000 to 2010. We got their SERA and sent it for testing at NIH for APOL1 genotyping. And our living donors, 1996 to 2010, they were sent to NIH for APOL1 genotyping. For recipient and donor characteristics, UNOS gave us data on deceased donors, and we had our own data on living donors. And Kaplan-Meier survival curves were used to compare graft survival, and then non-parametric test was used to compare time to graft loss. So we had 191 African-American deceased donors, and out of which 12% had high-risk genotype, which is quite similar to what's reported. 13% nationally, we are assuming 13% African-American population carries this high-risk genotype. So we had 191 out of 24 had high-risk genotype. We had 101 living donors, out of which 21 had high-risk genotype. Those 191 kidneys went into 298 recipients. And of course, the living donors went to 101 recipients. So total, we had 399 recipients grouped based on donor genotype, high risk versus low risk, 14% high risk, 86% low risk. So what we found was, we found no small study, we did not find any difference in graft loss between high risk or low risk population. We did not really find any difference in death-censored graft loss as well, although it was going towards significance. But we did find that median time to death-censored graft loss was lower in patients with low-risk genotype than with high-risk genotype. So the time to fail their allograft is, and it was up to 8 years, the time to fail their allograft was higher in patients with high-risk genotype. So presence of high-risk APOL1 genotype in donors was associated with accelerated graft loss in the recipient. That was all we could make out of our data in our patients. Now, that kind of brings us to the question, and it might be immaterial now, or we might need more studies on it in the future, is we used to have, up until last month, African-American race in our KDPI calculation, right? So, and it was sort of added on the premise that there is high incidence of graft loss, and maybe if you're thinking APOL1 is the factor that adds to it, right? So now, very elegantly done analysis published in AGT in 2018. So they sort of switch the African American race to high risk APOL1, sort of having a high risk APOL1 gene. So if you just switch, somebody is African American, if they have a low risk genotype, you don't give it points, but if they have a high risk genotype, you give it points. So overall, if you have low risk genotype, your KDPI score went from 71% to 53%, right? So this is all of African Americans. So if it's 17%, so 83% of African Americans in your population could have qualified for a lower KDPI. On the other hand, if you added the APOL1 gene variant, the KDPI went from 69 to 88%. So now, like I said, it's immaterial because now we have removed, as of earlier this month, last month, we have removed race from the KDPI calculator, but perhaps we might need to be a little more cognizant of calculating the genetic risk. It's hard with deceased donors, but now we are developing point of care testing, genetic testing. I think when that becomes available, we might be able to incorporate that in our risk assessment for deceased donors as well. Just forgetting donors for a second, I just wanted to mention real quick, coming to the recipients, APOL1 gene doesn't impact recipient outcomes. If your recipient has the APOL1 variant genes, it should not impact recipient outcomes. And this study just tells you the same thing. 2 risk versus 1 risk versus 0 risk. It doesn't impact allograft survival. So now shifting gears to what we really wanted to talk about, living kidney donation. So this was a case of identical twins, and for the nephrologists in the room, and maybe some of the surgeons too who can now read pathologies and on WebEx, this is a kidney biopsy that you'd never want your donor to have. This is a donor who went on to develop proteinuria kidney disease 7 years after donation, and this is a classic finding of collapsing FSGS. So when we did genetic analysis, we found that this patient had a G1 and a G2 mutation, so a combination of both, and predisposed this patient to developing kidney disease in the future. So going a little bit back, before we knew details, or even now we don't have data on APOL1 risk in APOL1 and risk of kidney disease in donors, but we know from the data that's been published, this is the landmark study that we quote about donation risk all the time, Dr. Mazel's study from JAMA in 2014. We have known as a fact that Black donors, the relative risk of donation is higher as compared to any other race. If you look at this blue bar versus the black bar, it's wider when it comes to Black race. So the overall risk of ESRD is higher in Blacks as compared to others, and it is the hazard ratio is higher, which means their overall risk is higher if it was same attributes but a Hispanic or a white donor. We also know if you incorporate gender into this equation, that Black males have the higher risk of ESRD when you look at that heat map, right? A young Black male over here, they have a highest lifetime risk of developing ESRD. And we've never really known or come to a definite conclusion why we see these differences, and could APOL1 explain these differences. We also know that biologically related donors have greater risk of ESRD than unrelated donors, and this is irrespective of race. So now, before I go into that, I wanted to share our experience from Detroit. When Dr. Goggins were here, she partnered with Wayne State and did this study of medical outcomes in African American living kidney donors, and they didn't find any difference in graft loss, but they did see that hypertension risk was higher in donors as compared to non-donors, about 40%. And this is what we quote to our African-American donors when we see them, that hypertension risk was higher. And absolute risk difference was 22.9%. And the relative risk in African-Americans in developing hypertension was, in adjusted model, was 1.7. So definitely higher risk of hypertension. They could not demonstrate a higher risk of ESRD. And now, like I said, put those differences in bigger studies in CKD, development of CKD be explained by APOL1. There have been case reports, there have been retrospective data, there have been population-based studies, but we really don't have much in terms of prospective randomized studies. Now, Dr. Locke from UAB, she looked at a cohort of patients from the Cardia study, which were like, this was a study that compared baseline healthy patients with similar cohort of established donors. And when they genotyped African Americans going back, what they did find was, and this is risk of chronic kidney disease, they did find that patients, African Americans with 2 risk variants, did have a higher rate of chronic kidney disease as compared to 0 and 1 risk variants, and as compared to their reference group that was European Americans. Again, this, and why would that happen? Theoretically, it would happen because you would say they already have that risk, and donation would serve as the second hit in these people to kind of push them towards proteinuric chronic kidney disease. Now, at our center, we've had a good subset of African American donors. So between us and Wayne State, mainly it was Henry Ford. From the study that I mentioned before, we had 136 African American donor. We tried to see if that would impact our function, CKD development. So we had 136 African American donors. 19 of them tested as high risk, and 117 low risk living donors. And these were the results. So APOL-1 high risk, which is 2 variants, were associated with both lower pre and post-donation GFRs. So our patients who had higher risk had lower GFRs to begin with, and they ended up having lower GFRs than our African-American patients who did not have 2 risk alleles. We did not find any association between 2 risk alleles with increased incidence of ESRD, but when we plotted the trajectory of GFR, how did the GFR decline? Okay, we did demonstrate that the rate of decline in post-donation GFR is greater among donors with high risk versus low risk genotype. And that's sort of been replicated with other studies as well. These results were, and when you look at the Cardia study also, similar rates of decline of GFR is observed between donors and matched non-donors if you group them by high risk versus low risk. So now, knowing all that we have, and until we have further data, we have 2 big studies going on. One is the Apollo study that Dr. Kim mentioned. It's underway. We started recruiting in 2018, but as you know, our African-American population, it's hard to recruit them also, getting them faith in the system to be testing their genes. So it's been hard to recruit for that study. So that study is ongoing, and we'll need several years of data to see where we are in terms of outcomes in donors. With donors, you just don't want their CKD risk at 3 years. You're looking at 15 to 20 to 30 years, perhaps their lifetime when we're looking at younger donors. And there's another, and Apollo is not powered to detect ESRD risk. So there is like an ancillary study. It's called the Leto study of the Apollo that's specifically looking at that as well. But until we have further data, and from what we have learned so far about the risk that we have in CKDs, in donors, we have conclusive data on APOL-1 in CKD. And we have inconclusive data on allograft survival and risk to living donors as far as APOL-1 is concerned. So now coming back, looking at our decision not to let George donate for everything normal but an APOL-1 risk factor, I think that is sort of the dilemma that we all face. And that's where some of the ethical considerations come in. And I want to kind of spend some time on this slide. And these are some of the ethical considerations that we have in our day-to-day life when we test these donors. So first of all, who should be tested, right? Should you be offering this to everyone? So now, as we learned, people who migrated from, or ancestors who migrated from West Sub-Saharan Africa, they have the greatest potential to carry these variants, right? Now, you also have some people migrating from East Africa who are termed as African Americans who don't have a risk of carrying these variants, right? And then you have some people from the Dominican and you have some people from the Caribbean ancestry who don't identify as Black, but they have a risk of carrying these mutations. So it's kind of hard on who should be tested. And then, race is self-reported. And we look at race based on what we feel the race could be, right? Based on physical appearance and other things. So I think who should be tested remains a big question in terms of you don't want to overdo testing. You also don't want to underdo testing. So I think that is something for all of us to think about when we think about, are we utilizing testing in an appropriate manner? Then the second thing is, should APOL-1 testing be offered? Should we just offer it? Should we require it? Some of us are requiring it. I think about 25% of programs in the country are requiring it. Or should we encourage it, even encourage it, for example? So from what we know from the studies on APOL-1, we know that it doesn't guarantee the development of kidney disease. 13% of the African-American population has the gene. Out of those 13%, 20% will go on and develop kidney disease. So if it doesn't guarantee the development of kidney disease and we don't have current data to identify those at risk, should we be mandating it on patients? There is, of course, a discordance between genotype, people who carry the gene, and clinical phenotype, people who manifest what happens if you carry the gene. So of course, you'll be giving more information to patients if they get it, but at the same time, you'll be encouraging stigma, discrimination, increased concern about health, insurability if you do these tests and you don't know what to do with that. So I think that is something else that we need to look at when we make decisions about offering this testing. Then what information should be shared when we are seeking informed consent? What decisions will we make in either scenario? And what's the data behind that? We have to let the patients know that the data is inconclusive in donors. There is data on CKD risk in population, in African-American population, but we really don't know what taking away one kidney would do to you if you have that gene in the setting of a normal kidney function. So what information should be shared? Second, then how should the results be used in living donor kidney transplant? Should you, if they are too risk positive, should you totally exclude them? Should you include them with a caveat and, as I said, discretionary donation? Or should you say, hey, they can just donate, it's their life, it's their decision? And then who should have access to APOL-1 test results? We say we consent everybody for high KDPI kidneys, right? So if we are convinced enough to decline a donor for 2 APOL-1 risk allele, and they or decline or have a medical opinion about the donor with 2 APOL-1 risk alleles, should we be disclosing, if we indeed end up going forward, should we be disclosing that to the recipient that, based on the data that we have, you might have a shorter allograft survival based on what we know. So I think those are some of the ethical considerations. I wish we had answers to those. We unfortunately don't. So are people ready to start testing? So the study looked at opinions of African-American adults about the use of APOL-1 genetic testing in living kidney donation. And a cohort of African-Americans were asked if, as a potential, after being educated for APOL-1, were asked if they were a potential living kidney donor, would you take the APOL-1 testing if it was free? And, majority said that they would take the test. But having said that, I will let you know that, we've had a hard time recruiting patients for the APOLO registry. So I think there needs to be increased awareness there. If we need to know more about it, we need to have increased awareness and involve the key stakeholders, that is the patients. How about patients who get those organs, right? So as a patient awaiting kidney transplantation, should kidney from a deceased donor with African ancestry being offered to you, undergo testing? And majority of these patients, recipients on the wait list, said yes. How about provider beliefs? So the American Society of Transplantation, they surveyed 83 nephrology fellowship programs and got opinions from nephrologists, surgeons, general nephrologists. And so all African-American potential living donors should be informed about the option. majority of the people said yes, at least the transplant nephrologist did. Potential recipients should be informed about their African-American potential donors with APOL-1 results. Now that's where it becomes controversial. General nephrologists did, but general nephrologists don't know, the details and the minor details of what we do on the transplant side. But that became a little tricky there. And African-American donors who have already donated should be tested. Like in retrospect, should we go back and test it? And, you see the answers, not very significant. So based on the data we have so far, these ethical considerations, things that keep on coming, almost every time we evaluate an young African-American donor at our selection committee. ASD had a work group, the Living Donor Community of Practice. They had a work group and they came up with the following recommendations. All potential living donors who report African ancestry should be informed about APOL1 gene and future risk of kidney disease. Genetic testing should not be offered at screening. So we do our initial screening, we do our medical psychosocial evaluations, our CAT scans, we follow up with whatever we need. And if they have passed all of that, that's when we bring up genetic testing. We tell them the pros and cons of the genetic testing. We tell them this is what it is. We acknowledge the lack of robust data. We tell them we don't have data, but based on what we know so far, this could be what your risk is. And counseling is very important after genetic testing, whether it's low risk variant or high risk variant. What ASD also recommends is isolated finding of APOL1 to risk variants should not be sufficient to rule out a candidate. Our risk of ESRD should be lower than the acceptable threshold of the program. Now, what is widely accepted is younger Black candidates, usually less than the age of 44, who have at least one risk factor for CKD, which includes obesity, family history, smoking, being a male is a risk factor, and a GFR that's less than 100 in a young patient, 44 and below. Those would be the ones who, if they are too risk allele positive, although we don't have data, but from what we have so far, those would be the one that we perhaps could discourage donation on. Transplant programs should not reveal the result of donor genotyping to the recipient for confidentiality, and potential donors with high-risk APOL1 variants should not be discouraged to donate just based on concerns of renal outcomes. We just don't have enough data so far. And that brings me to the end of my talk. Thank you.
Great. Thanks, Dr. Prashar, for that very interesting talk. This talk is open for questions. Dr. Brown?
Think that, so Dr. Brown's question was for the WebEx audience, that why do we recommend doing testing at the end of the evaluation rather than the beginning? So Dr. Brown, just because of the lack of data, you want to evaluate every possible risk factors, and a lot of them are evaluated at the time of, once we evaluate them. We don't get the big picture until we know. We have seen the patient, done the psychosocial, medical eval, CAT scan eval, and sometimes, it's not one risk factors, it's a combination of risk factors. So when it comes to a combination of risk factors, we feel that patients should have a complete assessment before we are giving them that final decision. So no, and that would be very significant for living donors. But they have looked at birth weight, birth weight and development of CKD, and if that was like an additional hit in patients with APOL1, and that was found, low birth weight was found to be a risk factor, which is like overall then hyperfiltration and things like that. We do, yes, we have all of that data. We have all of that data. Yeah. So no significant difference in our two patients that lost in our two donors that ended up failing the kidney. Both of them, Henry Ford donors, both of them were APOL1 2 risk allele positive. Good. So in the recipients, right? That's a good question. I have to look into that. I don't think there was. I think majority it was a regular thing, but I don't think that. You mean like diabetes and FSGS? Yeah, yeah. There was no difference. Yeah, but yes. I wish we did. I wish we did. And unfortunately, uh, UNOS mandates a 2-year follow-up on donors, and UNOS does not specify high versus low risk, whether it's APOL1, any other medical surgical risk. And a lot of these patients are lost to follow up. It's high to have normal people follow up. So no, we did follow up a bunch of people for this study, but over time, these people just, fall through. Dr. Alan Gardner. So I left those slides on purpose. I thought that might get a little complicated. So there is some data that in patients with even one risk APOL1 allele, there might be a circulating factor that increases the risk of TCMR. And this was actually, the discordance was, when COVID happened, there were a couple of kidney biopsies on COVID patients with low risk variants showing some of the findings you would see in high risk variants. And the hypothesis was that there might be some circulating factors. It's still a hypothesis for now, but there might be some circulating factor, especially with COVID viral illnesses, that might exacerbate, some podocyte injury and in transplanted patients, rejection.
Are there any questions from the online audience? No. So I do have one question. So for years, we've been selecting donors without this testing, and very few donors actually ended up to the point where they required kidney transplant. So are we just looking into things that may not necessarily be clinically relevant?
And I think that is the biggest dilemma. We might be. 13% of the population carries the gene, and 20% over their lifetime might develop clinically significant disease. So that's a very small number we are dealing with. But I think the data is out there, and the patients should know. Should we make those decisions for the patient? I think it should be left to them. In my mind, I think as long as the patient understands, they are old enough to understand, they don't have risk factors, you could actually, I was reading a paper, they compared it to a high versus low KDPI kidney and have that analogy for donors, right? So when we consent recipients for high versus low KDPI, we consent them for, this is going to be your risk of graft loss, but this is what you gain. And when we talk about discretionary donation, you mentioned kind of that same, aspect, or you kind of make the same analogy and you mention it to donors and say, this is the risk is, we don't know the risk. If you're willing to proceed, you could still proceed. It's hard to tell. It's hard to tell.
It is hard.
Loss. And then it's retrospective too, right? So we won't know. I mean, our study didn't show that. Somebody else's study did. So, the literature is all out.
Okay, well, thanks, Dr. Prashar, for educating us about the APOL-1 gene mutation. Hopefully, everyone got some good information. And thanks, everyone, for joining our grand rounds today.